दीपक कधी चालू करायचं मला सांग हं.
हो हो 2 मिनिटात आपण बघूयात अजून
हो
स्टुडंट्स.
चालेल ठीक आहे. मॅम आफ्टर द टॉक विल हॅव फ्यू क्वेश्चन अँड आन्सर्स.
So Deepak, whenever you are ready, you can tell me.
Yes, ma'am. In
Yeah.
2 minutes we'll start.
Yeah,
People are
I am here
joining
only. Yeah,
rapidly.
sure, no
Yes, ma'am.
problem. Take your time.
Yeah.
So I am getting constantly people from science.
Yes, sir.
This year also I got a very nice student. Last year also she is extremely good from science only for DNB medicine.
And
Passed out from science.
okay.
Yeah.
So I think now Cyan is among the topmost choices for people.
Yeah, yeah.
All yeah.
For the PG, no?
PG, yes, ma'am.
Yes, yes, really. Yeah. The teaching in other hospitals is not so much.
Yes, ma'am.
I
And
don't know.
exposure in BMC hospital, I mean, even in rheumat, what we can see here is hardly to get in private or anywhere else in out of in Maharashtra.
Mm-hmm.
Opportunity, and thank you to Dr. N.K. Singh.
Mm-hmm. Yeah, yeah.
Should we start,
Okay.
Deepak?
Yes, ma'am. Yes, ma'am. We'll
Okay.
start. We are about
Okay.
to.
So good morning, everyone. Thank you for joining us on Sunday morning. Today, it's a great honor to introduce our today's speaker, Dr. Jyotsna Oak, ma'am. Many of us, of course, know her. She's one of the senior most rheumatologists in the country and truly a teacher and mentor to generations of us. Ma'am is a senior consultant in rheumatology and medicine at Kokilaben Dhirubhai Ambani Hospital, Mumbai. She has previously served as a professor and head in charge Department of Rheumatology at Lokmanya Tilak Municipal Medical College and Hospital, Sion, Mumbai, where she played a pivotal role in shaping academic rheumatology and training countless clinicians. Today, we are really privileged to have her. She shares her vast experience on scleroderma spectrum, and she'll be teaching us the step-by-step approach to diagnosis and management for this particular difficult disease. Thank you, ma'am, for joining us today. Over to you, ma'am. Thank you once again.
Thank you, Dr. Gayatri, for a very kind introduction of mine. And I am still not a teacher so much, but I'm still learning and I know my capacity. So, Dr. Deepak had already promised me that whenever I am not going to answer, he is going to prompt me. Okay. And he also has a large experience working in Sion Hospital. So let's
Thank
begin
you.
today's topic of scleroderma. It's definitely a disease which is quite near to my heart because when you see ladies suffering from this disastrous disease where you can get a lot of bad end results of fibrosis of the skin, you always feel enthusiastic about learning more and more about this disease so as to prevent these complications of disfigurement and actually mental hazard which keeps coming along the course of scleroderma. So as we know, this was one of my very early patients of scleroderma who actually looks quite normal. And I always used to teach students that so many of rheumat patients can absolutely look normal in their early disease. But if you carefully see the signs of mild skin thickening or mild skin stretching on the face, you will be able to still pick up the patients who come to you with the non-specific complaints of arthralgia or myalgia. You have to have a kind of expertise to see whether the patient has got any other signs besides the skin thickening. So this was a disease which was actually seen way early in 18th century, and it was quite significant that the Raynaud, which Maurice Raynaud had described the Raynaud's phenomena, was also quite early manifestation, and that was also thought to be early manifestation of scleroderma during the 18th century. And then the description of William Osler also came, who said that this is the most hazardous, horrible disease where the patients actually get mummified. So we know that scleroderma is a generalized disorder and it can get characterized clinically by thickening and fibrosis. And this fibrosis and the thickening has got basis of vasculopathy and conversion of the fibroblast into myofibroblast, which are actually because of activation of some of the things which produce vasculopathy. So that is small vessel as well as medium-sized vessel vasculopathy, and that can produce again endless fibrosis. And this fibrosis is the mainstay of this particular disease like scleroderma. But it is not only the dermatological disorder, and we know that there is involvement of internal organs, actually the heart, lungs, kidney, and the GI tract. And that is why when you are managing the patient of scleroderma, you require to see whether any other system is also involved along with the skin. That is how you try to see, even if you have got classification as limited cutaneous or diffuse cutaneous. And this is a full-fledged patient wherein you can see a lot of stretching of the skin, which you cannot pinch at all. You can see the hypopigmentation. And here, this is a fibrotic, the end stage almost of a fibrosis, where the skin has become so thin and tight, and there are contractures of all the fingers, and there are also the pregangrenous changes. And this is someone who has not been at all diagnosed for a long time. This is something like a depigmentation which occurs again. And sometimes you can get features like depigmentation, but perifollicular depigmentation can still exist. And this is known as what is known as, salt and pepper appearance, which can be seen sometimes at the forehead of the patient. So if you carefully examine here, you carefully examine at different areas, you will be able to see. Sorry, you are able to hear me, no?
Yes, ma'am. Yes, ma'am.
Yeah, okay. Early patients of scleroderma can just have a mild sclerodactyly or thinning of the fingers, and you can see that there is tapering of the fingers, which can be seen. And the patients can come, of course, with the Raynaud's phenomena. So these are some of the clinical manifestations of skin involvement. And depending upon the involvement of the skin, they are really categorized into limited cutaneous or diffuse cutaneous scleroderma, and the sign is scleroderma, where there is no skin involvement, but their patients can be having internal organ involvement, and the skin involvement can come later on. When you are checking about the skin thickening, you should also know that there could be some drugs like bleomycin or some other drugs which can produce similar changes like eosinophilic myofasciitis or changes which are exactly looking like scleroderma. So these are known as scleroderma-like diseases, which are seen sometimes in kidney diseases as well. Localized scleroderma is then categorized into morphia, where only a localized skin can get affected in the form of either plaque morphia or guttate morphia, linear morphia, or N-coupe de Saber, where all the skin is really involved in a great extent. So this is because of the overproduction of connective tissue and collagen along the widespread vascular damage and vasculopathy. And because the incidence is extremely rare in the usual clinical practice, general physician may not be able to see many cases of scleroderma. It's only in the referral centers that you can get many patients of scleroderma. You know that because of involvement of other organs, the 10-year survival rate initially was very, very low, and it was basically because of cardiac and lung manifestations. Genetically, there could be some HLA types which are preponderant, and connective tissue, there is already have told you that there could be dermal fibroblast synthesis, which are increasing collagen. So this is altered response of fibroblast on which there is always a navigation of science going on as to how to prevent conversion of fibroblast or from fibroblast into myofibroblast. The downregulation of fibrogenic stimuli also could be one of the manifestations, and the triggering mechanism could be anything like outer things like microbial infections or pre-genetic kind of predisposition could be there. This activation requires to be halted if you want to halt the progress of scleroderma. In case of diffuse cutaneous, the onset of
I
hello,
I
hello, yeah.
Yes,
So
ma'am,
in
you can continue.
patients of diffuse cutaneous, it is not only the skin of the extremities which is involved, but also the truncal skin and the face is involved. So in limited cutaneous, you know that the skin which is below the elbows or below the knees will be involved, whereas in diffuse cutaneous, the truncal skin also is involved. So it is essential to know whether the patient has got truncal skin involvement, because these are the patients who could be having early involvement of the lung disease or the cardiac disease. They can also be having tendon friction rubs, and these patients have early involvement of the lung in the form of interstitial lung disease. Renal disease is also seen like oliguric renal failure, and they have severe manifestations of gastrointestinal and cardiac involvement in the form of myocarditis or cardiomyopathy. They are anti-topoisomerase positive, or we know as SCL70 positive antibodies, and they can, this is one of the prognostic features where you will be able to recognize that the patient could be having more vast manifestations. Where the patient has got Raynaud's phenomena, we'll come to it little later. You can do the nail fold capillaroscopy by either the help of ophthalmoscope, which can be used as a dermatoscope by putting the oil on the skin, and you will be able to see whether there is capillary dilatation, giant loop formation, or distortion of these capillaries. And wherever you can see the capillary distortion or giant loop formation, you know that this is a patient who has got pathological Raynaud's phenomena, or we know as secondary Raynaud's phenomena. We know that many patients are having Raynaud's phenomena going on for many years, and those patients who are diffuse cutaneous, the Raynaud's will be there for few number of years, whereas in limited cutaneous, the Raynaud's can go on for a long time. Patients who have idiopathic Raynaud's do not have these capillaroscopy changes at all, and that is how you can differentiate between benign Raynaud's and a patient who has got scleroderma. So in case of limited cutaneous, the skin involvement is limited only to the hands, face, feet, and they have usually the anti-centromere antibody positive. They can either be having CREST syndrome with telangiectasia with esophageal involvement, and the patients who have got sinus scleroderma, which are quite rare to see, they can have Raynaud's, but they usually do not have any skin involvement. But if they have ILD type of pictures, or they have a renal crisis and their antibody like SCL70 positive or anti-centromere positive, well, then they can be then typified as scleroderma, sinus scleroderma. So this was a older criteria which we used to use when we were students, that anybody who has got skin thickening proximal to the metacarpophalangeal joints, and the minor criteria was sclerodactyly. So if you have got one major and one minor criteria, or two minor criteria in the form of digital pitting scars and bibasal pulmonary crepitations, then you know that you can diagnose a patient of scleroderma based only on these clinical manifestations. But now we know that there is ACR and ULAR criteria where there is skin thickening has got 9 points. I'll just, yeah, the skin thickening has got 9 points, which is in the form of severe skin thickening, both hands extending proximal to metacarpophalangeal joints, and skin thickening of the fingers, fingertip lesions in the form of digital tip ulcers, abnormal nail fold capillaries has got good importance of 2 points, and pulmonary arterial hypertension has got 2 points, with ILD having 2 points. So even these autoantibodies, which are anti-centromere, SCL70 or topoisomerase, and RNA polymerase, they have got 3 points. So anybody who has got points which are weight on the highest score and has got more than 9 or 9 can be classified as definite scleroderma. Of course, these are the patients for the classification. So for your day-to-day practice, to give the patient treatment, you do not require to have all these points satisfaction. And this is only when you have got classification to be included in the literature. The patients are seen in the OPD with very minimal type of changes where there is no scleroderma, but sometimes in the early phase, you can get puffy fingers, which is known as a scleroderma phases, and the fibrosis can come little later. At the time of this manifestation, you can do the plain X-ray, try to see the terminal resorption of the tip of the finger, where it can be seen as a distance marked by the terminal phalanx and the nail pulp, and the nail pulp is shown to be completely resorbed in case of scleroderma. So this is episodic digital ischemia, which is provoked by cold and emotion. We know that Raynaud's can be seen. And the early stage is pallor, followed by cyanosis or blueness, and followed by hyperemia, or what is known as red discoloration. So what you can ask the patient, whenever you are exposed to cold, do you see that your fingers change the color? Or when you immerse your fingers into the cold water, do you get change in the color? And if this is so, if it is accompanied by unusual sensation of numbness and pain, then that can also be called as Raynaud's phenomena. This is one of the most characteristic feature of scleroderma, and I would always request my students to ask this question whenever you are suspecting a patient of scleroderma. So when you have got scleroderma with Raynaud's phenomena, all that you can do is to ask further questions about dysphagia, involvement of the lung, or I think you have to do something about this disturbance. Sorry.
Somebody, Mr. I think
Somebody has put on the mic.
Buster's iPhone. Who is Buster's iPhone? Please mute your audio. We don't know the name because his audio is only on.
Thank you.
Uh,
Lot of disturbances coming.
yeah, sorry, ma'am.
It's okay. So whenever Raynaud's phenomena is this is one of the most characteristic feature of scleroderma, and you have to ask the duration of Raynaud's, as well as you have to ask then the patient any accompanying features of scleroderma. And in such patients, one should do antinuclear antibody. If it is positive, then you know that this could be a patient of scleroderma. So this is the patient again with Raynaud's phenomena. So other diseases which can look like a scleroderma at this particular point could be eosinophilic fasciitis, eosinophilia myalgia, graft versus host disease, infiltrating carcinomas, and porphyria cutanea tarda. These are something which also can mimic scleroderma in the beginning. So I told you already that Raynaud's can be idiopathic or it could be secondary. And whenever you do the nail fold capillary microscopy as well as antinuclear antibody, you will be able to get the answer whether this is Raynaud's along with the scleroderma or not. So survival is again different in limited cutaneous and diffuse, but nowadays because of good therapy which is available, let us all really work for scleroderma patient to reduce the mortality as well as morbidity. The other involvement besides skin in the patient of scleroderma is, of course, I have to tell you that you have to see the fingers for pitting scars, loss of substance of the finger pad, telangiectasia has to be seen on the hands and the face. And I'll give you a picture of that. And of course, the cutaneous calcinosis, which is again one of the characteristic feature of crest. And calcinosis is very rampant in some of the patient of scleroderma. It increases over the years, and I have seen patients having severe pain when they have this calcium deposition at the iliac crest and also at the elbows. And there are very few drugs which can act on calcinosis, and we must have tried our level best. But in my own experience, whenever you are using immunosuppressants in a great proportion, you can get sometimes a reversal of calcinosis. The gastrointestinal tract is the most common system which is affected. 90% of the patients will show you. And this is not only the esophageal and small bowel disease, but also oropharynx. And they can have difficulty in swallowing. because of involvement of oropharynx, which is much more involved in polymyositis. And we always teach you that, okay, the lower part of the esophagus is the one which gets involved, but that is in the later stage. This is the patient of telangiectasia, and you can see that the patients on both the cheeks have got this telangiectasia, and she also has got hypopigmented area on the forehead. And you can now diagnose her as a patient of scleroderma. This is depigmentation, which can occur if the sclerodermas are never treated, and this is again one of the very irreversible damage of the skin. So coming back to the esophageal involvement, you can get abnormal mobility, gastroesophageal reflux disease, GERD, Barrett's esophagus, precancerous. When you are doing the scopy, you have to do this biopsy and see whether the patient has got any changes that can lead to adeno-CA. And this is one of the things that patients sometimes are not diagnosed when they have got weight loss, and it could be actually because of cancer, and they are sometimes predisposed to cancer like pleural effusions, adeno-CA. I have seen the lung cancers occurring in them. They can also get infectious esophagitis and pill-induced esophagitis. In the colon, you can get colonic inertia, you can get pneumatoceles, megacolon, perforation, and telangiectasia. They can also get bleeding. Now, for the evaluation of GI, you can do barium swallow, you can do manometry, or you can do the scintigraphy, which is again objective way of understanding the esophageal mobility. So this is the barium swallow, where you can see that there is lower part of the esophagus which is dilated, and this is manometry, wherein you can see the normal kind of esophageal wave. But in the case of scleroderma, you can see that the waves are not formed, and this is known as actually what is known as a very bad involvement of the esophagus, and you can get even at a very later stage the esophageal involvement. So the Barrett's esophagus is again a precancerous, and because of that, getting into real configuration of the esophagus is very, very important. To prevent all these problems of esophagus, you have to treat the GERD by either proton pump inhibitors or H2 inhibitors, and you can also give domperidone if there is no QT interval prolongation. Simple things like keeping a distance time gap between the last food and the sleep is very important. Having small meals at a time and not having food at all after 7 o'clock is extremely important whenever you are dealing with these problems of esophageal hypomotility and GERD problems. The renal disease is sometimes not diagnosed in patient of scleroderma, but as a routine investigation, one should do the urine examination to check for proteinuria, hypertension, because you know that these patients are prone for developing this. Patients of scleroderma who also have got associated Sjogren's can also be having proteinuria and the cast in the urine. And this is all because of reduced cortical blood flow, Raynaud's phenomena occurring at the renal arteries, that is vasospasm, and the other risk factors could be anemia, pericardial effusion, constrictive pericarditis, prolonged involvement of the cardiac with cardiac failure, renin-angiotensin increasing and producing less renal function and perfusion. And you can also get non-hypertensive crisis because of microangiopathic hemolytic anemia, which is one of the manifestations which is very characteristic of scleroderma kidney. Thrombocytopenia also is seen in these patients, and the treatment we know that is S inhibitors. When we were doing the post at that time, these patients, when the ACE inhibitors or ARBs were not available, these patients used to be landing up always in the nephrology, and we never used to see these patients because they were requiring dialysis at that point of time. So you have to be careful about knowing that the patient can have this renal disease, and whenever you have extra manifestations like proteinuria, do not hesitate to see that the patient has got any other overlap. The cardiac disease is again missed, and I have seen two patients who were taken up for the cardiology, and they both had suffered from myocardial infarct because of epicardial vessel involvement in scleroderma, and they also had got cardiomyopathy with dyskinetic apical segment with the clot. And that was a clot which was producing embolization and was producing kind of pre-gangrenous changes in the lower limb. So this is very important that every patient with scleroderma, you have to auscultate the heart to see for RV failure, pH, and also for cardiomyopathy. The pulmonary disease, as we all know, that is the mainstay for morbidity of scleroderma, and it is next involvement to GI tract. It is most common cause of death, and interstitial lung disease like diffuse scleroderma, it is always commonly seen. Severe pulmonary hypertension is basically seen more in limited cutaneous, but also seen in the longer duration patients of diffuse cutaneous scleroderma. So this is the most important thing about which we have to be aware, that it can cause severe interstitial inflammation, fibrosis. It is really pertinent to see that pulmonary vascular disease is existing or not, but it can produce also bronchiolactasis, spontaneous pneumothorax because of cystic disease, and the pleural disease, which I have seen very commonly sometimes with repeated pleural effusions. And in these patients, not only tuberculosis to be ruled out, but also malignancy. And I have seen at least 3 patients with malignancy with adenoCA of the lung. Aspiration pneumonia because of GERD, calcinosis also is seen, and pneumoconiosis in patients of silicosis with scleroderma is also seen. DAD is not particularly always seen in patient of scleroderma, but there are case reports of DAD which are occurring in scleroderma as well. So pulmonary hypertension, I'll come to it little later also. It's either a primary pulmonary hypertension and a secondary pulmonary hypertension because of interstitial lung disease. I always teach the students, scleroderma is one disease where you can get something like idiopathic pulmonary hypertension, but because of LV dilatation, because of ILD, and because of chronic pulmonary T, scleroderma is one disease where you can get all sorts of pulmonary hypertension. So the manifestations could be just dyspnea. On examination, you will get loud P2, and you will get, of course, SV3 gallop, and also the right ventricular hypertrophy with parasternal heave. You have to check for the patients of interstitial lung disease, and you have to take the patients also for pulmonary function test. So evaluation has to be done thoroughly to check for all the manifestations and then to come to a right conclusion. So the patients can come to you with just mild haziness or reticular appearance in the lower zones, and they can, on the HRCT, they might see a continuous, a very advanced kind of ILD. So ILD is basically a diagnosis by suspicion. Whenever you are get velcro rals or you get mild fine crepes at the base, you try to check. Nobody does inflammatory bowel fluid or bowel. It was done when patients were not, categorized by the chest CT. So chest CT, when it was not available, people used to do the bowel fluid to see whether increased neutrophilic appearance is there, to check whether the patient has got early interstitial lung disease. So evaluation of the interstitial lung disease, you know that SCL70 is the one which correlates with the diffuse scleroderma and genetic factors and anti-centromere antibody. So this fibrosis, the mainstay, actually it is occurring because of macrophage activation. And if you do the pathology, it can show you a patchy lymphocyte as well as the plasma cell infiltration. Endothelial epithelial injury is the main thing, and it causes interstitial edema. So in the beginning, there is alveolitis. Followed by that, there is also the vascular component. And usually in patients of scleroderma, you get non-specific interstitial pneumonia, or you get mixed pattern with NSIP as well as UIP pattern. The mean alveolar wall also can get increased in the size. So if you want to just stage the patients of ILD or the pulmonary fibrosis, if the patient has got less than 3 years of duration and the PFT is showing restrictive lung disease, then you can check it either by BAL, or you can do the contribution with for pulmonary hypertension by doing either echo or Doppler. All patients whoever have got worsening dyspnea have to be categorized for ILD. And if the HRCT is showing ground glass appearance, you know that the patients can be having lung inflammation. This is only when the patient has got advanced disease. I would now request you all to see it as early as possible. So do the HRCT right in the beginning for estimating correctly the ILD pattern. So the treatment of pulmonary fibrosis, I will go to it a little later. And these are the usual trials to stop the pulmonary fibrosis. But there are no such current drugs which are available which can completely halt the disease by giving anti-fibrotic drugs. And we'll come to it what are the screening and monitoring of the interstitial lung disease. So whenever you have got interstitial lung disease and there is a risk for the ILD, what you can do is the pulmonary function testing to check whether the patient has got restrictive lung disease by spirometry, lung volumes, and DLCO. Of course, we will be doing HRCT, and by understanding the HRCT pattern, like whether it is NSIP, UIP, how much lung area is involved, you can diagnose ILD. If you have diagnosed ILD correctly, then you check the pulmonary function test, and in patient of systemic sclerosis, every 3 to 6 monthly, up to 1 year, you can check it. Later on, if the patient has got stable disease, then you can check it every yearly. In patients, whenever there is ambulatory desaturation, then the testing should be done much more frequently. And you can also do the HRCT whenever you're expecting or you're suspecting something else which is occurring in the chest. So if the patient has got sustained dyspnea, it is okay. But if the patient categorically says that dyspnea is increasing, then you have to check whether the patient has got any lung parenchymal disease which is different than the ILD. The drugs which are used for the ILD for systemic sclerosis, this is as per the EULAR guidelines, they are mycophenolate, tocilizumab, and rituximab for the first line ILD therapy. And there are very good articles of tocilizumab improvisation and rituximab, and the patients in whom there is no good response, you can use cyclophosphamide, nintedanib, and azathioprine. So upmost upfront drugs are mycophenolate, sometimes cyclophosphamide if the patient is having a problem of uh, taking mycophenolate because of diarrhea. Nintedanib, of course, there are a lot of publications of nintedanib, and azathioprine is used for the maintenance therapy. There is always mentioned that there is strong recommendation against the glucocorticoids, and they are not used routinely in all the patients of ILD, and that is because of renal crisis, which is a fear for using glucocorticoids. But all of us know that in patients where there is exacerbation of ILD, we have to use glucocorticoids in small dosages for a shorter duration. So decision of glucocorticoid dose and the use of oral versus intravenous therapy depends really upon the severity of the disease, and they should be used cautiously in patients who have got systemic sclerosis because of increased crisis, renal crisis. So this is something which you have to remember. Patients who have got progression of ILD in spite of using the immunosuppressants, then you add the switch therapy. In patients of systemic sclerosis, if you are already using mycophenolate, then you can go to tocilizumab or rituximab. And again, if it is not useful, then you can use cyclophosphamide. Autologous stem cell transplantation is referred only in patients who are admitted in the experience center, and it is not available in all the centers. But there are case reports and there are series of this which is used in patients of relentless progression of lung disease in systemic sclerosis. And that is the reason why this is also mentioned in the guidelines. So this is very important to know. Again, long-term glucocorticoids are not to be used. Additional recommendation for the progressive ILD again is either sometimes IV glucocorticoids, and two additional therapies which can be used are again cyclophosphamide or rituximab. So patients who have got topoisomerase 3 positive, patients who have got diffuse scleroderma, you can use cyclophosphamide or even IVIG when you are suspecting sometimes diffuse alveolar damage. Calcineurin inhibitors and JAKi also are used in uh, progressive lung disease, and this is something which you have to check it. So if there is no such kind of MD5 suspicion, then only we can use it. If there is suspicion, then you can use again different disease, this thing like rituximab. I must mention about pirfenidone and I must mention about nintedanib because these are often used in progressive pulmonary fibrosis by the pulmonologist. And in my own experience, I feel that these drugs may be having little benefit in patients of systemic sclerosis. Pirfenidone has various actions like inhibition of Th1 to reducing the ability of T cells and so on and so forth, and also having something against the TNF alpha. So pirfenidone is used very commonly for UIP in rheumatoid arthritis by pulmonologists, but sometimes the patients of Indian category may not be able to tolerate pirfenidone. But since it is used as antifibrotic, and if the patient has got unstable disease or the disease is progressing, then you can use pirfenidone. Nintedanib trials of scleroderma have been over, and it has been used very routinely by the pulmonologists in all the patients of scleroderma of NSIP pattern as well. And that is because the effects are good. It reduces the collagen synthesis and fibroblast formation. And also it has got all these actions against the VEGF, tyrosine kinase, and so on. So it has a broad spectrum of effect. Coming back to the antifibrotic, the new drug for the UIP pattern or progressive pulmonary fibrosis is nerandomilast, and this is again used now in patient of systemic sclerosis where the trials are going on. So FDA has not given yet a permission, but FDA has given permission for progressive pulmonary fibrosis, and they will be soon introducing it or doing the trials in patient of systemic sclerosis or UIP pattern of rheumatoid arthritis. Cyclophosphamide we were using very commonly in patient of scleroderma in the beginning, and that is why all these trials I have kept it. But nowadays, cyclophosphamide is used in very extensive disease, and the early publication of cyclophosphamide was always in scleroderma for the diffuse alveolitis, and they were given in systemic way of cyclic way of giving cyclophosphamide every 15 days or every monthly. And whenever we use cyclophosphamide in cyan days, we thought that even the dermatological manifestations went down because of cyclophosphamide. So still in many patients, we use cyclophosphamide whenever there is bad disease of scleroderma ILD. So this is ILD scleroderma, and I'm sure you all know it. High dose immunosuppressive therapy is not something which is used in practice, but you can read about it, how it is used, and what are the results of this immunosuppressive therapy. Corticosteroids, we said that it can be used in a smaller way. And the last but not the least is lung transplantation, which is to be advised to the patient if the patient has still got progressive disease after using rituximab, after using IVIG, if the patient has got very severely affected FVC and DLCO in patients of ILD, then lung transplantation is the only answer. Yet in India, we have very few centers who are taking these patients for lung transplantation, and full evaluation of the cardiac system is required before the patients are sent for lung transplantation. In our own series, where we could see that the cardiac involvement was also seen, and the Raynaud's and skin involvement was seen. And as far as lung involvement was there, we got the patients who have got diffuse systemic sclerosis having much more lung involvement. The other aspect which is very serious in patient of systemic sclerosis is of course pulmonary arterial hypertension. And again, it is something which you require to see in each and every patient of scleroderma. So the patients of scleroderma, when we saw these 54 patients and we had presented it in the conference, we got 16% of the patient had pulmonary hypertension, and the other patients also had got, in all these patients, the pulmonary hypertension was quite severe, and we had to take these patients for the therapy as soon as possible. Little bit about how the patients get pulmonary hypertension in systemic sclerosis. It is all because of endothelial injury and upregulation of vasoconstrictive endothelin 1 and thromboxane A2. Producing vasoconstriction causes vascular remodeling, and that is a reason for pulmonary hypertension. There could be association with microthrombi, hypoxia, increased vasoreactivity, and the left ventricular disease also can be there in systemic sclerosis. So in systemic sclerosis, you have LV disease, you have extrapulmonary vasculature also getting into it, and the microthrombi and vascular remodeling, especially of the small arteries, which all are responsible for producing pulmonary hypertension. Just quickly about endothelin, because we are going to use anti-endothelin receptor blockers, and endothelin is the main broad this thing for producing proliferation as well as vasoconstriction. It is also leading to inflammation and fibrosis of the pulmonary vessels. And if you see the ET1 levels in they are always increased in systemic sclerosis, also in idiopathic pulmonary hypertension. And that is why doing the drug therapy with anti-endothelin is very important. So patients who have got isolated PH have shown to have a very faster rate of a disease, and they have shown to have 5 years of the first non-Raynaud's phenomena manifestations, and patients tend to have other organ involvement. So whenever the patient has got PH, they definitely would be having other organ involvement, and they will be having severe pulmonary hypertension. Those patients who have either limited cutaneous scleroderma or severe diffuse cutaneous manifestation. So the other way, when we are dealing with pulmonary hypertension, all of us cannot do the right heart catheterization, and patients are not willing for the right heart catheterization. Even though it's a gold standard, what we do in our study is a tricuspid jet velocity. And when this tricuspid jet velocity is less than 2.5, there is no pH. But if it is between 2.5 and 3, well, you can have either dyspnea or you can have no dyspnea. If the patient's dyspnea is really explained by some other cause, then there is no pulmonary arterial hypertension. But if it is not explained by any other cause, then you suspect PH, and then you can do the right heart catheterization, or you can take up the patient for therapy for pulmonary hypertension. Those patients who have this jet velocity more than 3, they can be having suspected PH. So the cumulative survival of PH definitely is much less in patients of PH with systemic sclerosis than patients without systemic sclerosis. So systemic sclerosis PH is more severe. The years after the diagnosis, they have got mortality, which is much more. And because of perhaps other organ involvement, they don't do as well as the patients of idiopathic PH. So evaluation or the screening test, the right heart catheterization is a gold standard, but you can do echocardio, you can do pulmonary function test. And if you have DLCO, which is disproportionately lower than the FVC, then you know that there could be a patient of pulmonary hypertension. 6-minute walk test, echocardio, electrocardiography to see for the P pulmonale, and medical history, all that is included in the prior evaluation of a patient. So you should check the end stage symptoms, whether the patient has got any right heart failure. This is the patient where actually have already got decompensated disease. So early symptoms of PH
अरे वाह
are again to be
काय
always
पाहिलं
taken.
त्यानं
Physical
विचारलं
examination
तुम्हाला
is very, very
दोन गाड्या ओव्हरटेक
important.
आला
The patients who have got loud loud P2, early systolic ejection click, murmur of tricuspid regurgitation, right-sided fourth heart sound, right ventricular heave, and this is very important for the clinical examination. Only on auscultation, we can understand that the patient could be having pulmonary hypertension, and only on auscultation, you can understand the patient is having ILD. So you don't require fascinated kind of investigations when the patient comes to your OPD for the first time. It just requires careful history taking and careful examination. When you do suspect that the patient has got loud P2, please do not hesitate to do the echocardiogram. And even though it is not as sensitive as right heart catheterization, well, you can check this patient that he could be having definitely pulmonary hypertension. The other things which you can do is HRCT, chest, CTPA to rule out pulmonary embolism, or you can do the pulmonary function test to check for DLCO, as I have already told you. When you do the echo, you can suspect that the patient could be having
आपल्याला
pulmonary
बैतूलला जावं लागतं
hypertension, and then you can check
Excuse me, ma'am.
for the.
Dr. Ajay, please mute your speaker. Dr. Ajay Dafale, please mute your speaker.
Thank you. Once you confirm the pH, then you can go for the targeted treatment. And the targeted treatment is I told you that isolated reduction of DLCO, you can suspect that the patient could be having PH. So this is again the clinical endpoints, the board dyspnea score. These are the endpoints which are used for all the drugs which are newly invented for the patients of pulmonary hypertension. So if you read any trials, you will always check that these are the endpoints like 6 minutes walking test, clinically time to get clinical worsening, non-invasive, and the board dyspnea score, and so on. So you know that these are the indices. This I will skip it. Now the targets of therapy for the PH is either by endothelin therapy, endothelin 1 receptor antagonist, and you know that ambrisentan and bosentan are there. And nitric oxide pathway, you know that this phosphodiesterase PDE5 inhibitors are there. And you know that in the patients who have got very critical problem of severe pulmonary hypertension, you can use all these prostacyclin derivatives which can cause vasodilatation and anti-proliferation. So this is prostacyclin derivatives like ipoprostenol, elopras, treprostinil, and endothelin receptor antagonist are bosentan, ambrisentan. We are all using it. And also the phosphodiesterase inhibitors, that's sildenafil, which is used as a first line drug. Now, the main thing you have to understand is that you have to not only categorize these drugs, but you can use all of them together also as one by one if the patient is not responding. And we have also seen very dramatic results when the patients are given combination of drug therapy in these different categories of the drugs. So management could be same as idiopathic PH, but you can it was recommended that anticoagulation therapy is recommended, but nowadays it is again not used and not recommended. Diuretics and digoxin are also sometimes used in patients who have got right heart failure, and they also show very good response when the patient comes with right heart failure. So immunosuppressants, because we know that the pulmonologist will always be using antifibrotic, but we will be always recommending that you have to use immunosuppressive therapy in patients also of pulmonary hypertension because they are going to have vasculopathy. And if we use sometimes drugs like intravenous cyclophosphamide or sometimes even rituximab for suppressing the immunological reaction, the patients of severe APH also have shown good response. So in many retrospective studies, it has shown that the patients of PH did respond to the first line immunosuppressive therapy. So there is a role of immunosuppressive therapy even in pulmonary hypertension. Prostanoids, I have already told you that the first class of drugs for the approval of PH and intravenous ipoprostenol is approval for the treatment. This is all for the WHO class 3 and 4 symptoms and labeling in some countries and for some generics, including CTD kind of APH as well. So ipoprostenol, inhaled eloprast is again used as emergency medicines, and you can read about it as the trials of class 3 and class 4 patients of APH and treprostinil. So there are some drugs which can be given injectable. There can some drugs which are given in IV like eloprast, and some drugs which can be used as inhalers. And we have been using these drugs in critical patients of pulmonary hypertension. PDE5 inhibitors are used, of course, as the first line drugs in pulmonary hypertension, and they are also used for patients who have got digital ischemia and digital scars or digital pitting scars. So this is sildenafil, which is used for many, many years, and we know that it is also used for pulmonary hypertension. And only thing is that they should be taken approximately 4 to 6 hours apart. And as per the available clinical evidence, dosages can be increased if it is required. No dose adjustment is required for
Excuse me, ma'am, we can't hear you. Ma'am, we are unable to hear you.
I think ma'am logged off. I'll just connect with ma'am.
Yes. Hello, everybody. Till then, you all can put your questions in the chat box. We'll take them later.
I think it will be, I think it is coming again. Yeah, yeah, yeah. Okay, wait a minute. Now I'll have to again share the screen.
Share screen is visible.
Yeah, yeah, but wait a minute. Yeah, this is visible now.
Yes.
Yeah, okay, sorry, there must be a problem of connectivity. I hope
No
I was
problem.
audible before that.
Yeah, ma'am.
Yeah. So tadalafil is again indicated for the treatment of pulmonary hypertension. I told you about sildenafil and then tadalafil, and both these drugs are used very, very commonly. And there could be combination of tadalafil as well as ambrisentan, bosentan. And the recommended dose of tadalafil is 40 milligram, but I don't think we are using always in all the patient. 20 milligram we start with, and there could be a problem of renal impairment. So if the patients have got some problem in the creatinine, you have to again monitor the patient. And if the patient has got any renal impairment, you should start the patient with 20 milligram once a day. In patients with hepatic impairment, there is a mild to moderate risk and consider starting again the patient with 20 milligram. So tadalafil again requires monitoring of renal as well as hepatic functions. In bosentan, we are not using it anymore much, but ambrisentan is very commonly used. Uh, Bosentan has again shown very good results with 6-minute walk distance, and this was a breathe one trial where bosentan was used first. Just take this up, then I am not able to see the heading. Yeah, sorry. So bosentan is again, compared with sitazentan. So in this group, you have bosentan, ambrisentan, sitazentan, and macitentan. And macitentan tablets are also available. And whenever the patients have not shown improvement with these drugs, or you can add macitentan if there is no improvement. So selective these ETA receptor antagonists are approved in Europe and US, and they are all used very commonly in India as well. So this is ARIES 1 and 2 trial for ambrisentan, and liver enzyme elevation was not much seen. So this was the conclusion of this ambrisentan trial. And conclusions then on pulmonary hypertension, it is associated with many connective tissue disorders, and it can present later in patients who have got the diffuse scleroderma, and in patients of limited cutaneous also it can be seen. You can use prostanoids, you can use immunosuppressant drugs, and you can use the combination of all these drugs in patients who are very refractory to pulmonary hypertension treatment. So the treatment in patient of scleroderma, as we all have seen, it's a very chronic, disabling and disfiguring disease. You can get not only this, you can get fatigue, you can get myositis, cold intolerance, lot of pain in the joints, deformities because of contractures. And in patients of diffuse disease, to be recognized as early as possible, you can check for the capillary dropout on capillaroscopy, and you can check antibodies of SCL70. And therapy could be really very wide now. You have got anti-cytokine antibodies. Now there are trials going on anifrolumab, anti-interferon gamma inhibitors, pre-translational inhibitors, and these are the new drugs which will be coming sooner, I feel that, in the coming years for the treatment of scleroderma. So we are using some of these drugs, but plasmapheresis when the patient has got renal failure or pool IVIG. And the non-selective immunosuppression can be done with methotrexate. We don't use it when the ILD is there. But yes, we use a lot of azathioprine and we use cyclophosphamide as well. So this is non-selective immunotherapy like cyclophosphamide, mycophenolate used for systemic sclerosis, ILD, as well as skin manifestations. Maintenance therapy with azathioprine or methotrexate. T-cell targeted immunotherapy like cyclosporin, sirolimus, especially in patients of myositis. B-cell therapy like rituximab, especially in ILD patients. And biological immunotherapy when patients have got very severe joint problem. And these are not something which are used very commonly. Antifibrotic therapy like fresolimumab and imatinib mesylate are still on the horizon. And I am sure that in the coming years, we may get some antifibrotic drugs like nerandomilast can also be, that is Boehringer Ingelheim's, and it can also be approved perhaps later on for the patients of systemic sclerosis. So, in patients of Raynaud's phenomena, I have forgotten to tell you about the non-drug pharmacological therapy like psychological therapy, oral vasodilators like calcium channel blockers, then 5-hydroxytryptamine like tryptomer, etc. S inhibitors like and ARBs both are used. Topical vasodilators are used for 5 PD inhibitors are used, and antiplatelet drugs are again very much recommended, and that is because of vasculopathy. So we can use clopidogrel, we can use ecosprin, and even fluoxetine. Surgical procedures. Whenever the patients of Raynaud's phenomena have got digital ischemia, one has to rule out that there is no embolization, there is no atherosclerosis, there is no actual some kind of hindrance in the blood flow before we try to take these patients as Raynaud's because of uh, systemic sclerosis. So this is something which is the last slide of mine. Thank you so much.
Thank you, ma'am, for such a wonderful, lucid, and highly practical session. You have beautifully simplified very complex disease into very simple thing and have given very clinical pearls for all of us. And I am deeply grateful for you for this enriching talk. So we'll now open the floor for question and answer session.
Yeah,
So
sure.
kindly post your question in the chat or raise your virtual hand.
Am I audible now?
Yes, ma'am, you are audible.
Yeah, okay.
There is a question, ma'am. Does pulmonary hypertension severity correlate with disease activity in the initial stages of scleroderma?
Yeah, in my own study of 114 patients, we had seen that those patients with, I did not say about the modified Rodnan skin score because it is not very practical to do it in the typical practice, but it has got some correlation with pulmonary hypertension, the severity
Yes.
of the disease in diffuse cutaneous scleroderma. But what I have observed is that the longevity or the duration of the disease is definitely, correlating to the pulmonary hypertension. Instead of correlating that, what I would say practically that each and every patient of scleroderma should be seen from the point of view of pulmonary hypertension and the ILD, because these two are the most gruesome problems of systemic sclerosis. So you should assess separately pulmonary hypertension, how severe it is, whether the patient requires treatment, and most of the times the patients become symptomatic only when they are walking or climbing up the staircase. So they can be missed out. And that is why
Yes, ma'am.
baseline ECG, baseline 2D echo has to be done in patient of scleroderma, and then 6 monthly you can do the judgment again.
Yes, ma'am. And even baseline HRCT should be considered in patient with scleroderma. Do
I
you
would
think?
say yes, at least whenever you are trying to see that they have got any symptoms, or if they have got dyspnea on exertion, or they have got dyspnea after walking a certain thing, I think you should do, because mainly you can be missing NSIP because it is only mild subpleural involvement. And in
Yes,
such
ma'am.
patients, if you give immunosuppressants right in the beginning, like mycophenolate, they do well and they don't
True.
progress then.
True, ma'am.
Yeah.
And for refractory Raynaud patient, what do you consider if they
Yeah,
are
I
not
didn't I
responding?
didn't
Yes.
mainly elaborate main on Raynaud's because we are not into such kind of a cold weather. But yes, up north there are patients who are absolutely horrible Raynaud's. So one thing is they had suggested was a sympathectomy, which we have done it in patients when I was in KM, because at that time the calcium channel blockers had just come. But I think so sympathectomy is indicated, and local patches of nitroglycerin has been indicated, and basically you have to tell the patient not to get exposed to cold when they should wear thermals, meaning it is not only the mittens or the gloves, the central body core temperature has to be taken care of. That is, none of the patients take care of that, and they should really not get exposed to cold water because that they are always working with the cold water. That is one thing. But refractory Raynaud's is a difficult thing, and the patients, when they come to you only with the Raynaud's, you have to rule out cryoglobulinemia, antiphospholipid antibody, or the digital ischemia because of some other reason like embolism, atherosclerosis, etc. But
Yes, ma'am.
I think you can answer if you have any other things to be offered.
Now, one more thing we are using, ma'am, prostaglandin analog, which is
Yeah,
available,
that I said
alprostadil.
already.
Yes,
Iloprost
yes.
infusions we
Yeah,
have said already.
yes, ma'am.
Yeah, Iloprost, Topastanil, both are used, and
Mm.
also vasodilators have to be used, and
Yes, ma'am.
5-FD inhibitors have to be used.
There is a question, ma'am. Methotrexate versus azathioprine for systemic sclerosis, PH or ILD. I think,
Yeah, but that will
yeah.
be like
Ah,
individual preference because
yes, ma'am.
I do not usually use methotrexate in patients of ILD, but many of
Yes,
the rheumatologists feel that it doesn't aggravate, and there are case reports and there are series saying that methotrexate can be used. But my
yes, ma'am.
personal opinion is because of the hypersensitivity pneumonitis and they can get cough already, then it is difficult for you to manage. Azathioprine is better tolerated.
Yes, sir.
Yeah.
Dr. Vanraj has asked if scleroderma patient has a subclinical ILD on a HRCT like 10 to 15% GGO or like less than 20% involvement with
Yeah.
normal FVC 6-minute walk test.
Hmm.
Should we wait or start treatment only when there is a functional decline? So in this scenario,
Yes, so as per the guidelines, in such a patient who have subclinical involvement and who do not have any abnormality in PFT as well as walking test, they do not recommend any treatment. They say that you
yes,
can wait and do again after 3 monthly or 6 monthly HRCT, or you can do the PFT. But I personally feel that you can at least introduce immunosuppressant in such a patient if they have
yes,
got
ma'am.
also the skin involvement.
Yeah, and now
Because
with
these
the
guidelines sometimes, even if you take it, if the patient worsens, you always have lost that window of opportunity.
yes, ma'am. And with
Yeah.
now the tocilizumab trial, they
Yeah,
have shown,
tocilizumab
yeah,
trial I have not taken because it would have been too lengthy.
yes,
Tocilizumab
ma'am.
has been effectively used for the patients of PH, I mean ILD patients, and it has shown good results. And many
Yeah,
people are using tocilizumab in patients in whom there is again diffuse scleroderma and ILD.
yes, ma'am.
Yeah.
Uh, Best immunosuppressant to reduce skin tightening. Uh, from your point, ma'am, for scleroderma with only skin thickening, which you
Yes.
prefer, methotrexate, MMF, or Ritux, and how do you increase or shift medicines?
I have been using mycophenolate, and sometimes with a very bad skin involvement, I also use a small dose of a steroid, even though no clinical reviews have shown any efficacy of a steroid. But at
Yes,
least in the scleroderma stage, I have
yeah,
seen a good improvement in small dose of a steroid, which is
okay,
given over many days. So
okay,
mycophenolate and steroids I have used. I have also used cyclophosphamide in patients who have got calcinosis cutis and a very severe skin involvement. But my own experience is that nothing works on telangiectasia. And there are
yes,
patients who have got very visible telangiectasia all over the face, on the extremities, because of the dilated venules. And none of the treatment has actually shown any improvement. So if
okay.
somebody can answer that question for me, I will be happy.
But telangiectasia, it is actually difficult. Dr.
Difficult, yeah.
Gayatri, ma'am,
And telangiectasia are the patient who get renal involvement, who get bad involvement like hypertension.
yes,
And
ma'am,
that is like a clue, that this patient could be having
pulmonary
renovascular
hypertension,
problem, or patients could be
renal,
having hypertension.
yes,
But the
ma'am,
telangiectasia doesn't go down at all.
Madam,
yes, ma'am.
lasers may have a role.
Yeah, laser, that is
Yeah.
by the
Those,
dermatology,
I mean, but
only on the
we
face.
hardly have any patients coming because they are so worried about their sclerosis that they hardly
Yeah.
come for the telangiectasia. But
No,
lasers
but
have a role.
laser
Yeah.
has definitely a role. And I have few patients who are long-standing scleroderma. They don't have anything else, but the telangiectasia bothers them.
Yes, ma'am.
uh,
Yeah.
ma'am, from student point of view, like if a patient, how do you differentiate basically clinically from scleroderma mimic from scleroderma? Uh,
Yeah. So basically, if the scleroderma is there, like puffy fingers or early involvement of the skin, And if the patient has got history of Raynaud's and myositis type or arthralgia, the best thing is to do the anti-nuclear antibody because
Yes,
it is really positive in patient of scleroderma. And there are many other antibodies as well. We
yes,
don't do capillaroscopy in all these patients, but what we can do is that you check for the other involvement like lung, pH, etc. But if you get ANA which is negative and
oh,
you don't get any other clue, then it is difficult. Then you can do only the skin biopsy. It's a localized patch of morphea. Then you
yes,
have to do skin biopsy only. Or you are suspecting eosinophilic fasciitis, then deep skin biopsy has to be done.
yes, ma'am. And they don't have Raynaud's and other features that also.
Yes, the other
Yes.
people will not have Raynaud's.
Dr. Shabnam has asked about treatment for GI manifestation in scleroderma.
Yes,
Uh,
because of lack of time. See, one is a
I,
esophageal involvement and dilatation of the esophagus, which is very bad. And this is something which bothers the patient than more than anything else. So one is that they can get small quantity of food more number of times. They should have a good gap between their dinner and the sleep time. And they should be combined with not only the proton pump inhibitors, but along with domperidone. And domperidone acts quite well, but sometimes even this thing fails. And
yeah,
you have to give something like a locally acting drugs or gyneton or something like that. So like Mucane gel or some other drugs also can be used, but they require these drugs for a prolonged period that is there, and they should be evaluated whether they have anything else like hiatus hernia. In one
yes.
of the patients, I can tell you my experience, and he was having very severe vomiting, and they had all thought it was esophageal involvement. So when we did the HRCT, there was a hiatus hernia. So we thought it
Oh,
was because of hiatus hernia, but actually what he had was NMO disease, and he had a demyelination at the cord. And because of area
oh,
prostrema demyelination, he was vomiting.
oh,
So vomiting is something which you require a thorough investigation if they
very
have
true.
vomiting.
Madam, any role of diltiazem in GI effects, GI side, GI?
Yeah, so diltiazem is used for Raynaud's, and what happens is that it produces more laxity of the lower esophageal sphincter. So paradoxically, it increases the symptoms of GERD.
Yes, ma'am.
Yeah, so you require a more different drugs when you have a esophageal involvement as well as Raynaud's. So you use calcium channel blockers for Raynaud's, but it can increase the GERD manifestation sometimes. So you avoid the drug at night.
Yeah,
That can be done. And supine posture you can avoid. You can tell them to take a backrest or two pillows like that.
okay. If patient desires pregnancy, scleroderma, specifically scleroderma ILD or PH patient,
Yeah.
is it safe or not?
pH is never safe in
Never
any
safe.
pregnancy.
Yes, ma'am.
ILD is depends upon how bad the ILD
Safe.
is. But I have had patients with twin pregnancies with pH, and they had a very, very bad results, but we could somehow save them. Basically, in pregnancy, they can be also having anti-Rho and La positivity. They can
Mm,
get cardiac problems. They can get congenital heart block type, and they can get oligohydramnios. In ILD and the later pregnancy, they will have problems, and they will have problems of the cardiac involvement as well. So they require very close monitoring. They require control of blood pressure, control of hypoxia. They require prolonged admission in the hospital.
yes, ma'am.
Yeah.
Multidisciplinary team is the
Yeah. So
one
they
thing.
require multidisciplinary team, and you have to play a good role.
Yes, ma'am.
Yeah.
I think we have covered almost all the questions, ma'am.
Yeah. So I'm
Yeah.
extremely thankful to all your arrangements. And if I must be wrong or I must be little less in many kind of
N-
scenarios, so you will have to pardon me. And it
No,
is only to
ma'am.
provoke you for further reading. That is it.
Yes.
Yeah. Okay.
But
Thanks a
you
lot.
have covered everything, ma'am. Thank you
Yeah.
very much.
Thank you. Thank you
Thank
so
you.
much.
Thank you.
Thank you.
Thank you.
Yeah.
Thank you, ma'am.
Thank you, Meghna. Thank you so much.